Thank you, Bailey. Good morning. My name is Kelly Mast. I'm Coalition Manager for NASHPID, the National Association for State Mental Health Program Directors. And I'd like to welcome you to today's SAMHSA-sponsored webinar titled Youth in Crisis, Supporting Youth Through School and Clinic-Based Mental Health Programs. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have ASL interpreters who should be spotlit on your screen. During the presentation, please add your questions and comments in the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please, excuse me, there will be a brief survey that will show in your browser. Please take a few moments to complete that for us and let us know how you enjoyed today's presentation. Sorry. Thank you again for joining us, and I will now turn this over to Jackie Zimmerman from Mental Health America, who will introduce our speakers and will give a brief overview of today's webinar. Thank you, Jackie.
Perfect. Thank you, Kelly. And thank you all for joining us. I see our numbers going up. Feel free to head to the chat, give us a greeting, let us know where you're tuning in from today. We would love to hear from you. Welcome to today's session. We're so grateful to have you here joining us today for Youth in Crisis, supporting youth through school-based mental health programs. My name is Jackie Zimmerman, and I'm the manager of public education partnerships and e-learning at Mental Health America's National Office. I'll be here to help moderate today's session, and I'm joined by our speakers from the Dallas Independent School District, or Dallas ISD, for our second webinar in this series. If you missed the first, that's okay. We have a recording of it. There was some wonderful information shared during that first session. So I can put the link to that in the chat here shortly for your viewing later. Today, for our session, we'll be focusing on how youth facing traumatic episodes have developed unhealthy coping skills that are negatively impacting their academic success and developmental growth. Our speakers will offer helpful strategies for addressing trauma and grief, substance abuse, and other barriers that can negatively affect student learning, growth, and development. Please note that this training is about the mental health crisis among youth and not specific to youth with acute crisis needs, but we'll be discussing a variety of topics and exploring how school and clinic-based mental health programs are really supporting youth in the Dallas Independent School District. We have with us today three speakers from Dallas ISD, Dr. Deborah Purge, who is the Center Manager at Dallas ISD, Dr. Tracy Brown, the Executive Director of Mental Health Services at Dallas ISD, and Crystal Areola, who is the Center Manager for the Mental Health Services Department for the Dallas Independent School District. So welcome, speakers. We're so thrilled to have you here today. Before I hand it over and we get started, we just want to note this disclaimer. You can read our slide here today, but the views and policies and opinions expressed are those of our authors here today and do not necessarily reflect those of SAMHSA or HHS. We do want to again thank SAMHSA for sponsoring this webinar and remind folks that this will be recorded. The slides, recording, and certificate of attendance for live attendees will be sent out in the next week. Feel free to utilize the chat today. Like I said, give us a greeting. Let us know where you're tuning in from. And throughout today's session, we encourage you to engage in the chat, share your own experiences and resources, and also ask those questions you have for our presenters. We'll have some time at the end of today's session to really go into those and have some time in Q&A. So we'll be collecting those as you ask them and have some time at the end to review. So without further ado, I will hand it over to our Dallas ISD staff. Welcome. We are so grateful to have you joining us here today.
Yes, thank you so much, Jackie, for that warm welcome. And thank you, Kelly, for all the hard work that you guys have put into getting us here today. I Before we get started, we do want to thank Mental Health America and SAMHSA for this opportunity, because every opportunity that we have to talk about student mental health is an opportunity to change lives. And so I'm here with my colleague, and Jackie just mentioned, Dr. Brown, who will be speaking, and Crystal Areola. So we just want to thank everyone for being here and for joining us today. Just a few friendly reminder, while we're waiting for everyone to come in, please remember to mute your mic, and I think that's already muted for you. And as Jackie asked, please put in the chat, let us know your name and where you're joining us from. And if you have any questions, please feel free to put them in the chat box. Some of them will have an opportunity, Crystal and I, to have an opportunity, or Dr. Brown to answer some. If not, we will wait until the end when Jackie will ask the question and we can answer those virtually. Thank you so much. Let's dive in. So the learning objectives that we have for today is we're going to be providing strategies for working collaboratively in schools and community partners to provide a systemic approach to mitigating the effects of adverse childhood experiences on children's learning and growth. And then the second part of that is to increase awareness of how to effectively implement trauma-informed practices throughout a school-based mental health program. So we hope that the information that we provide to you today will somehow influence the way that you show up and you serve students going forward. So I was watching a conference that was for psychologists, and Dr. Murthy, the U.S. Surgeon General, was there, and some startling numbers that he had, and he said, there are three numbers that continues to stay on his mind, almost plagues him. And I've listed those three numbers here for you, but I reversed them in the order that he presented them because I wanted to share an impact that shows why it is so important to have a school-based mental health program. So the first number that we'll talk about is 36. So according to the Surgeon General, 36% of high school students stated that they have had persistent sadness and hopelessness before the pandemic. Because as we talked about last week, a lot of people talk, well, since COVID's been here, we're seeing this sadness and anxiety and depression, but it actually started the 10 years prior to COVID. There was already an increase in the number of students that were experiencing this persistent sadness and overwhelmed and hopelessness before the pandemic. The other number that he talked about is that in the decade before the pandemic, there was a 57% increase in the rate of suicide. 57% increase in the rate of suicide. So this is before COVID. So if you can imagine, this mental health issue that we're facing now has been a mental health crisis way before the pandemic hit. And the last number for me that was really heartbreaking is 11. So from the onset of a symptom, it takes a child 11 years, 11 folks, 11 years until they're able to access treatment and care. Can you imagine how many students and how many individuals are showing up less than their best self because we were unable to provide the services that they need? It took 11 years from the time the symptom first exhibits itself to receive treatment. Folks, this is a mental health crisis, and we've got to do better. We've got to make some changes. And so what we're hoping is that some information that we provide will allow you to chop that number to less than 11 years. When it comes to student mental health, it matters and they are important. Some other numbers that we will talk about are, where are the stats today? So before I get to the stats that's on the top, I'm going to talk about what National Alliance on Mental Health Illness says. It says 50% of mental health illness in youth will surface around age 14. And each year, 1 in 6 youth ages 6 to 11 will experience a mental health disorder. According to the Center for Disease Control and Prevention, in their youth risk behavioral survey, 42% of high school students reported having feelings of persistent sadness and hopelessness. So this looked at a 10-year period of time from 2011 to 2021 and was published in 2023. According to Mental Health America, which is our host today, their state of mental health in America in 2023, 6% of youth reported a substance use disorder in the past year, while 10.2% will be diagnosed with a substance use disorder in their lifetime. 6%, folks, right? And so the next data coming from Mental Health America is that 60% of youth with major depression will not receive any mental health treatment or care. Those are some of the students that are showing up in your classroom, in your campuses. And later, as we look into adulthood, those are the individuals that are forming a relationship, that are interacting with each other, that are showing up in the jobs. And sometimes we wonder, well, what's going on with the person? Well, because they fall into those 60% of youth with major mental health issues that have not been provided services to help them heal. The last stats that I wanted to talk about today was, where are we right now with the suicide rate? And yes, I realize that preliminary data coming out of COVID shows, as someone said last time, that suicide was the first lead-in. Those are the preliminary data coming out of COVID. But according to the data that we have from NAMI in 2023, suicide was the second leading cause of death among individuals between the ages of 10 to 11 years old. So that's where the major data says right now, but the preliminary data are showing that suicide is number one currently. Okay, so one of the things that we wanted to talk about is we cannot do and talk about trauma-informed care or how to serve students, but really without looking at the ACE study. So one thing about the ACE study is that our experiences in a relationship, starting from childhood all the way into adulthood, can impact our overall health and well-being. So the adverse child experiences are traumatic experiences that occur, and those experiences are things like emotional and physical abuse, domestic violence, substance use, mental health illness, even divorce and separation. And those ACE, they can impact how our health and our mental health emerges as we go from conception to death. The study found that there was a direct link between childhood trauma and early onset of chronic illnesses, incarceration, employment, and even early death. The higher the ACE scores that you have is the higher the likelihood of negative outcomes. According to Robert Bloch, who is a former president of the American Academy of Pediatrics, and I'm going to read quote, "Adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today." I'll read it again. So adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. Folks, that is a public health epidemic. So if those ACEs are not addressed, then we have students that are not showing up in school ready to learn. Some of the important findings of the ACE studies show that 67% of the population have at least one ACE. 1 in 6 will report 4 or more ACE. And then if you had 6 or more ACE scores, that can lead to death, which is about 20 years earlier than someone who does not have any ACE at all. So those numbers are pretty startling. The ACE costs America about $748 billion annually. $748 billion annually. So like we said, it is more costly for intervention than it is for us to educate and prevent. So it also showed, and I'm going to just jump around and did just a few of the stats. So 14%, 14 times the number of suicide attempts if you have 4 more ACE. There is 4.5 more likely to develop depression. It's 2 times the level of liver disease. And it's 3 times the level of lung disease and adult smoking. There's also 11 times the level of intravenous drug use. So folks, this tells us if we don't deal with the ACE, these adverse childhood experiences that our students are bringing into the classroom, that they're that they're experiencing these traumatic events that are shaping their lives, then we don't have children and students that are ready to learn. So I am going to turn it over to Dr. Brown that has, she's going to tell you about this video, and we're going to continue to talk about ACE. Crystal Ariola will dive a little bit further into ACE. And so, Dr. Brown.
Right. Well, thank you, Dr. Purge, and so excited to be here. Again, thank you to Mental Health of America and SAMHSA for this opportunity. Before we watch the video, you've heard a lot of stats around what our kids are experiencing as they enter our school buildings every day, and the experiences that they're coming in with. Oftentimes, staff doesn't understand what's happening. What is happening with this child, not just from an ecological standpoint, but just from a biological standpoint. What's happening with this child that is influencing their behavior? So we want to kind of give a very practical illustration and demonstration from Dr. Dan Siegel. He's out of UCLA, and he gives a great representation of what's happening in the child's brain that indicates that these behaviors might be an effect of trauma. So if you'll play the video.
One of the most rewarding experiences for me has been to study brain science and apply it to the experience of parenting. And the hand model of the brain that I use to teach parents is very useful to understand that. So if you take your thumb and put it in the middle of your palm, put your fingers over the top, this is a very useful model of the brain. And when we can actually see in front of us what's going on in the brain, then we can change what the brain does. So let me walk you through very basically what happens in this brain and the structures in it. And it goes like this. The spinal cord comes up, representing the wrist, and then you have coming up into the skull, the brain stem and the limbic area, which work together to help regulate arousal and your emotions and the way you have a fight, flight, freeze response. These are below the cortex, the limbic and brainstem areas, and the cortex is this higher part of the brain that allows us to perceive the outside world, to think and reason. And this frontmost part of the brain, right behind your forehead, so the person's oriented like this, is actually the part that regulates the subcortical, limbic, and brainstem areas. This regulation is very important because sometimes we can have all sorts of things happen in our life. We're tired, we're exhausted, someone pushes a particular emotional button, and we can flip our lids. So rather than being tuned in and connected and balanced and flexible, we can lose all of that flexibility, even lose moral reasoning, and act in ways that are terrifying to others, including our children. Now, you can actually bring yourself back online and come back to the high road and make a repair with your child, and that's important to explain it to them. And you can also use this hand model of the brain to explain to children, even as young as 5 and 6, how to understand when their emotions are rising up from the brainstem and limbic areas here, and how it's overriding the prefrontal area and making it so they may be about to flip their lids. So I've had kids come tell me that they're about to go flip their lids and they need a break. They need a timeout. And by even just naming that, they can tame it. And that's the power of using the hand model for ourselves and our children to help us all make sense of what goes on in the emotional communication that we have in the course of day-to-day life.
All right. So we wanted to play that video because in our district, we have been working with the Care and Purpose Institute to implement TBRI, and I don't know if you've heard of it, but it's TBRI stands for Trust-Based Relational Intervention. And when we go around the district and we're training our school teams, this video actually catches the attention of staff. It gives you the science behind the behavior, which is important because, as you all know, kids are in class with a teacher. The behavior is being exhibited. The teacher may not be a mental health professional. They may not know the science behind the behavior. So they respond in a way that really doesn't help that child to just kind of bring down, and as Dr. Siegel talks about, kind of brings down those emotions where they can reason and they can think through and process through what's happening with them. So we wanted to just play this video for you, just to, like I said, give you a visual representation of what's happening, what could be happening with that child, especially children that come from hard places. And for us, it's the starting point of conversations we have with school staff as to how they can begin to support students in a different way. So at this time, we're going to have Crystal to take us further. Crystal?
Actually, I do the next one, so go ahead. Go ahead. Crystal is coming up.
Sorry, Dr. Verge, thank you.
No, that's okay. So when we look at what trauma looks like, how it shows up. So what are some of the things that can cause traumatic experience for children? We're seeing in the news these days, there is a lot of school violence. So there's bullying, gun violence, and fighting. I don't know about your district, but in our district, we're seeing some of these things. There is family and community violence. There's physical, sexual, emotional, and abuse and assault. There's neglect and abandonment, suicide, homicide, loss, grief, or death, medical trauma, or serious accident. Right now, in the past, we've seen a lot of immigration issues, and I'm going through them now, but I'll talk only about a few of them because I know we're all familiar with these types of traumatic experience: terrorism, war, human trafficking, kidnapping, and natural disasters. I know a lot of you, whether you're in Texas or not, have really heard about the Uvalde shooting. And I brought that up because when you think about the number of lives that were lost in that shooting and the number of lives that were changed, it didn't just impact one student or one classroom. It impacted the entire school, the entire community, the entire state of Texas, and the entire United States and people outside of the United States. And so we call those are, even though I wasn't directly there or my child might not have been directly there, they're secondary trauma. It was played over and over again on the news. The information was constantly in the news being talked about. But those lives of those children that were lost and the parent, those are, so something that may start in one area then just consumes and touches the lives of people that are around. I often say it is, you cannot be outside of a system looking in. We're all part of a system. And so when something impacts one part of the system, it throws the rest of the system off balance. And as we look on the news, there are constant, I think, I can't remember which country in Europe they just talked about. They had not seen a gun violence in a long time, and those students are now experiencing gun violence. It is not just here in Texas, it is not just in the United States, but unfortunately, it is coming closer and closer and hitting home. These are some of the students that we're seeing showing up in our classrooms, and we expect for life to go on, but these students are stuck. We talked about human trafficking is another one that's pretty big and very traumatic for the students who survive. We have family right now whose family are part of wars in other countries outside of the United States, but they impact them here. If I'm worried whether or not my grandma is alive, and you want me to come into classroom and be my best self, last night CPS might have came to my home and took my siblings, or immigration came and took my parents. But you want me to show up in classroom and be the best version of myself. It is so important for us to be able to understand what trauma looks like. And it isn't every student who may be experiencing trauma may exhibit what we call willful disobedience, we'll talk about in just a little bit. You have a child that may come into class and they're quiet. They're not engaging, they're not participating. Well, what happened? When we dig deeper, my grandma died. My grandma was the person who always took care of me. What is now going to happen to me? So unless we change the way that we view children's behavior, we'll never acknowledge the injury and the damage that trauma does to the students that we see. Now, Crystal.
Thank you, Dr. Purge. And so kind of to build upon that, and I was seeing some of the commentary, right? Some of the trauma that the kids are experiencing in schools, some of that relational trauma, some of those boundary crossing behaviors, and what Dr. Purge had indicated, right? Sometimes you have those kids that as a result to trauma, yes, we could see that disobedience, that aggressive behavior, some of those acting out. You can have some students who are going into hypoarousal and they're isolating and they're not engaging and they're dissociating and disconnecting. Or you can have some students, even with a trauma response, right, trying to have those perfectionistic strategies, right? I'm going to try to meet every single thing. Their anxiety levels kind of go to a point where they are stressed, and it's not hopeful or beneficial stress that we'll go into a little bit more in a minute. It's that toxic stress that Dr. Brown will talk about a little bit later in the presentation in terms of how this is impacting how we show up in the classrooms, and even for our staff, right? We're seeing higher rates and higher levels of school staff and teachers indicating secondary trauma or vicarious trauma as a result of what they're experiencing within their environment, or as a result of what they're hearing and seeing of what's going on with the students in their classroom, and trying to bridge and engage them academically and emotionally and behaviorally in serving all these different roles. So according to the National Child Traumatic Stress Network, some populations of children and families are at a higher risk of experiencing trauma and victimization. So these populations may experience stress or some of that toxic stress or acute stress at multiple different levels and face different adversities at the same time. So effective treatment and access to services can be challenging. So some of those types of stress or some of those adversities that they could be experiencing, it could be substance use disorders in the family. As a result of that, there could be family violence that they're witnessing, neglect, emotional neglect, financial neglect. Maybe there isn't safe or stable housing, so some of that economic stress. Families that are migrant or military or veteran, right? They're being exposed to different war zones and different populations or different events that could be impacting their ability to regulate, to be present, as it said in that Dan Siegel model, their lid is flipped and they are going down into their limbic system. They're going down into that downstairs brain and trying to survive. So there's more of those post-traumatic stress responses. Youth who experience homelessness, a lot of times some substance use disorders could be happening. There could be violence happening in the home. They can be feeling not supported, neglected, LGBTQ youth a lot. So a lot of times there's something happening in that home where youth is falling into that category of homelessness or running away because it's not safe for them to be in that environment. And we know that they're at higher rates of depression, of suicide, of mental health disorders because they don't have that foundation and that network. So I think especially for us as people in the community and people in the systems or us in the school system, is how do we bridge those conversations? How do we connect with each other in order to help instill hope into our youth and into our families and into our community? And honoring the resilience, right? Because hope and resilience are a catalyst for repair and for the recovery process that we're hoping to implement, as well as individuals with intellectual or cognitive disabilities. They are at a higher risk of neglect and abuse and traumatization. And so we're wanting to start kind of bridging those conversations, trying to see those interventions earlier on, trying to mitigate some of this response to some of these traumatic events and experiences. So according to SAMHSA, trauma results from an event, series of events, or a set of circumstances that is experienced by the individual as either physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, or emotional, or spiritual well-being. And so when we think about trauma, right, the big T and little t of trauma, we have to look at it from different lenses, because for some people you're like, oh, that's not a traumatic event. That wasn't something that was stressful or anxiety provoking. But when we think about trauma, right, the event happens, it's the experience of that individual. It's their own unique lens that is affecting how they experience it, and it creates those effects moving forward. And so a lot of times when we're educating the community or even educating the parents, because the parents are like, oh, I didn't feel like that was such a big situation or that was traumatic. And when we're talking to the child, they're like, no, this impacted me. And now I'm scared. And now I don't feel safe. And I feel fearful because of whatever the event was in that situation. Then it's like bridging that gap of understanding and connection that is so powerful. As we're moving forward and having these conversations, right? So some of those considerations of trauma is, right, what are some of those risk factors, right? So distancing from traumatic event, previous exposure to traumatic events, mental health issues or disabilities. There could be some genetic components that may be happening in the family or some other physiological responses that could be also tying to this outside of the trauma event. Parents with either mental health or substance abuse issues, little or no social support or isolation, strain or stress on the family. So this could be financial, housing, food, work stressors. And so we know with the pandemic, a lot of people lost their jobs. There wasn't consistency or stability. So there was a lot of dysregulation that happened there. And that provided a lot of stress for our community. And then if we add it, I know for the state of Texas, around the same time that the pandemic happened, there was that winter storm that created a lot of housing instability because a lot of people had pipes burst, they had lack of electricity, and they were being displaced from their homes without having something consistent or safe housing. We also fear of a loved one. So grief plays a huge role. We saw with the pandemic, a lot of loss of life due to COVID or complications as a result of COVID, but we also have loss and fear as it relates to community violence, or even suicide, right? Mental health disorders, people completed suicide. And so that fear of Is my family, is my loved one, is my community safe? Are we okay? And how are we kind of having that conversation of, and even in the schools, right? And after Uvalde, and not just Uvalde, but the other school shootings that have happened, a lot of times coming into the classroom or coming into the school can provoke stress and anxiety for the youth that we are working with on a daily basis, as well as the socioeconomic status of the family, and environmental and developmental challenges that exist within the community. And so some of the trauma responses that we can see, yes, we can see those overt behaviors, which is the aggression, the yelling, the outburst, the fights, but we could also see the other extreme of a person being isolative, they're lethargic, blunted affect. Some of those psychosomatic symptoms, aches, pains, medical conditions. I mean, sometimes we see youth kind of develop, and we've seen this in our schools, as they're developing non-epileptic urogenic seizures, where when they are feeling overly stressed and their system is being taxed, that they are disassociating and going into that seizure-like state. Emotional outburst, dysregulation, apathy. In terms of behavioral concern, right, these are inability to focus in the classroom, lack of self-regulation, substance misuse, in which the student is trying to numb or cope or or regulate themselves in a maladaptive way. And so a lot of times people, the teachers may be, oh, they're just hyperactive, or they're not focusing and they need to be placed on medication. And so when we're having those conversations, it's like, let's talk about trauma in the brain. Let's talk about ACEs. Let's talk about attachment and ruptures that these students have experienced. Because a lot of times it isn't ADHD. A lot of times it's trauma that's manifesting itself in a behavioral way. And so trying to create some of that awareness and education is such a huge component. Another trauma response, right, is some of that cognitive dysregulation, difficulty in processing or comprehending intellectual challenges, unfavorable academic outcomes. So if a child is dysregulated, if that lid is flipped, their prefrontal cortex is disconnected, they're not going to be able to focus. They're in survival mode, right? They are attuned and attentive to any potential risk factors that they have, and potentially jumping into that fight, flight, freeze, or appease moment in terms of a trauma response, and as well as an impact in interpersonal and social relationships. Again, some of that isolation, inability to make meaningful connection, propensity to get into relationships that may cause unnecessary stress, unhealthy boundaries that are kind of presenting themselves as well. And so some of the factors that increase anxiety, right? So we see some of that anticipatory anxiety. So past trauma can cause children to worry if the traumatic event will happen again in the future, and can lead to concerns about personal safety or safety of others. Some of that separation anxiety, so anxiousness and being distressed, can come as a result of separating from their loved ones or caregivers. Some of that trickle down effect, right? So children can take cues from their parents as to how they deal with traumatic events. So if the parent seems worried or uncertain, the child will feed on that anxiety or anxiousness that they see in the parent. It's like, well, if my parents are stressed, then I should be stressed. Or even then, right, if there is stress in the system, and that toxic stress that Dr. Brown will go into in a little bit, then they're going to feed into that too. So if family is stressed and we respond in substance misuse, if we respond with outbursts and aggression or minimization, the kids are often going to do what they see, right? Sometimes the saying really goes, they follow more what we're seeing in action as opposed to what people are telling them. So we want to have our words align with our actions as we're kind of bridging that gap and developing resiliency and hope in our community that we're serving. Social media or media coverage can also create a lot of stress and anxiety, a lot of fear, because everything is so accessible. Sometimes there's a lot of misinformation, and that can impact how people are coming into our session. It can impact how we're presenting ourselves. It can impact that vicarious trauma and that vicarious stress. Peer talk, right? Children often talk amongst themselves and they can share that misinformation. So we want to make sure that we're bridging that gap in terms of mentorship, education, communication, collaboration, in order to bridge some of that connection moving forward. And so, yes, we know that there is healthy stress or youth stress, right? And that is the beneficial stress that can kind of motivate us. It can focus our energy. It can improve our performance, our feelings of excitement and satisfaction and well-being. It impacts us both physiologically and emotionally. But there's also that acute and toxic stress that is also impacting us physiologically and emotionally in a way that is more challenging to deal with. And as well as like drills and lockdowns, right? Because of what we're seeing in media, because of what we're seeing in the world around us with school shootings, community violence, sometimes students can have some anxiety that is provoking in them, right? When a drill or a lockdown happens, because they're like, is this a drill or a lockdown? Or is this actually something happening and my life is in danger and am I at risk? And so it's how are we de-escalating? How are we providing debriefment, not only for our students, but also for our staff, right? It's that continuum of how are we attuning to the needs of our whole system.
All right. So, and every one of the two, in each of the two presentations that we have had so far, this being the second, I have a favorite slide. And this by far is my favorite slide because I think it's such an important slide. Not that the other information isn't important, but we're talking about a paradigm shift. We're talking about a complete shift in the way that we view the behaviors of children. And so we're looking right here at the after effect of trauma. And we often heard the saying that says, this is only the tip of the iceberg. So when we say that this is only the tip of the iceberg, that leads us to believe that there's a whole lot more to come. The iceberg theory, when looking at the iceberg theory, Hemingway said, there's always more to the story than what we see. And in his work, it's stated that the things that are not written or that isn't put directly out there, that's the important part of the story that gives context to the story. And so as we look at children's behavior, there is what we see, which is really easy because we can see it. What's harder to grasp and take someone showing up with curiosity is what we don't see. So the behaviors that we see on campus are the trauma impacts the neurodevelopment and behavior leading to issues with behavior, emotion, and self-regulation. So we're seeing the hitting and the fighting and the biting and the cursing and the big behaviors. But some of the important things that we don't see is how this relational trauma or how complex trauma impacts the brain. So during trauma, the brain learns to constantly stay in the downstairs brains that we've been talking about. That's the survival brain. And so it's constantly on fight or flight. This is familiar to me. I've been here before. I'm fighting or I'm running. This is what we're seeing in the classroom. And when our brain is constantly in the downstairs brain, it means that our ability to reason and be logical is not working as well. We're not able to control our emotion or self-regulate as we normally would if our lips weren't flipped. So let's also look at, for example, the biology. So trauma affects biology in ways such as chronic activation of the hypothalamic pituitary adrenaline axis, and that maintains balance. And it maintains the homeostasis, the balance, and it comprises the immune response and how genes are expressed. So, for example, a simple example that we think about is trauma causes transgenerational legacy, if that's what you want to look at. So it can be passed on from one generation to another. So an example could be for a parent who was part of 9/11. They experienced the traumatic events of 9/11. Yeah, it was strangers who came and put us in harm's way. So now mom in her mind is, I'm very afraid of strange people that I don't know. I get really anxious when I'm around people that I don't know. And so let's picture this mom who is walking in the mall. And there you have Santa Claus. And she's walking with her daughter in the mall. And when she comes across Santa Claus, she pulls on her daughter. Now, the daughter's innocent, did not know what happened to mom back in 9/11, but what the child got from mom was that Santa Claus was to be feared. And so even though Santa Claus is harmless, that has now changed that brain function of the child, right? So we talked a lot about the epigenetic changes that is a result of trauma. So epigenetic, it doesn't change the genes, it changed how the gene that is expressed. So this child would normally not be anxious around Santa Claus now developed this sense of, oh, wow, I am hypervigilant around Santa Claus because there's danger, because my mom tugged on me. So now mom has passed her anxiety onto her child. There is lots of biological changes. So for example, you may, the trauma could impact you and cause sensory issues. So it could be that you are so afraid that you are a sensory seeker. So I need things that are calming to me. I am not able to control myself unless I have things that are externally outside of me to help calm myself. Or there may be certain sounds or sights or experiences that triggers my sensory system and puts me on overload. So now I have tactile sensitivity that I would not normally have had I not been through this experience. Let's look at the body. So trauma alters, and I'm going from the bottom up because usually we talk about the brain first, right? But I wanted to make a point about these are all the things that comes below the behavior. So when we talk about the body, trauma alters how our senses experience a sensation of our own body and the world. You know, I don't know if I can trust myself to control myself. So our body has these complex neural network and feedback loops that allows us to be able to have a sense of what's going on in the world. I have a general sense. I know what to expect. When you have relational trauma, the relational trauma comes in and the relational trauma impacts that. And so your body produces chemical, and the chemical is usually able to protect you from any threat, whether real or perceived. When you have complex trauma, your body continues to constantly build this chemical. And when the body does not use it, the over excess of the buildup of this chemical in your body, instead of being helpful, it becomes harmful and dangerous to your body. And then the other one that we'll talk about is belief. If I don't feel good about myself, if I don't know that I am worthy and I am valued, then how do you expect me to have self-efficacy? How then can I have the ability to do this? How do I know who I am? There is so much going on. I hear what you tell me. I hear what the experience has told me. But who am I? And then do I have the ability to control myself? So relational and complex trauma impacts the way that we show up in relationships. It impacts the way that we express ourselves. It impacts the way that we view the relationship that we are in with others or the way others interact with us. Trauma impacts us. And remember, with the brain, biology, body, beliefs being impacted by trauma, it's being expressed in our behaviors in the schools. And so if I don't know who I am, how can I be of value? If I don't have the ability to do something, how can I be any good? Can you imagine if this is a student that is showing up in the classroom and what you see is that I am angry? And underneath that anger, what is the need? So I see the behavior, but what is the need? We have to show up with curiosity to understand. Oftentimes we listen to give a response. We do not listen to understand. We do not show up curious because we figure we already got we see what's going on. And so then if we only look at what we see, then our response is punitive. If we show up curious and meet the need, then we say that this is a mental health crisis and we need to provide the appropriate intervention services that can help restore, that can help to bring about balance and healing from trauma. So we challenge you today that when you see a child in your classroom or on your campus or in your agency that has been referred for a particular behavior, ask yourself the question, what is the need that I need to identify in order to help this student be the best form or version of his or herself? Dr. Brown?
Right. And so thank you, Dr. Purge. So the question is, we've talked about a lot of stats. We've talked about trauma and the impact trauma has on the brain, the body, the biology, the belief system of the student. And so, we see all of these things happening. We see the results as relates to anxiety, depression, sadness, hopelessness. We see the impact. And so the question is, what can schools do? And I wanted to just kind of draw your attention to this quote that came from the movie Tipping the Pain Scale. And the quote is, "The obstacle to treatment is not the absence of pain, it's the absence of hope." And so the question is, how do we help children from hard places see that glimmer of hope that they need, to give them the motivation that they need to say, hey, I've gone through this, I've suffered from trauma, I have grief, I've had all of these adverse childhood experiences, but there is still hope. And in my awesome privilege of being able to be a teacher in the classroom, to be a school counselor, to be a mental health clinician in our district, that was really like 90% of the work, is helping children to understand what's happened to them, helping them to understand their experiences and understand that they can make it through those experiences. But the best way we feel that occurs is through meaningful connections and then being able to see the whole child. And then taking an ecological approach to treatment. So the goal here, and in our district, in mental health services, we ask all of our clinicians to complete a complete psychosocial on students to understand, yes, the presenting problem, but to go deeper. And going deeper means we're asking questions about medical history. We're asking questions about the home, about the family, about grief and loss, and what has occurred in this child's life that is bringing them to this place of needing help and needing hope for their lives, even medications. And I don't want to leave that out. I think even thinking through, okay, if a child is taking medications, what impact is this having on behavior? So as we talk about side effects of medications, that's critical. And it's important for school staff to know. It's important for those that are interacting with children on the day-to-day basis. They need to know what's going on with the child so that they can best help meet their needs. So we talk a lot about treating the whole child, taking a very holistic approach to that child's needs. And then the key piece is building meaningful relationships. And we are really excited in Dallas ISD that we've done some research and we've done some tracking. And we can now show that when our mental health clinicians touch a child, we have a 3% recidivism rate back to our alternative school. So where the general population of students that may not receive mental health treatment in our district, there's about a 20 or so percentage of recidivism to alternative school. But we know if a mental health clinician touches those kids and provides the needed services in terms of counseling, therapy, family therapy, psychiatry, and so forth, we know that we're closing the gap for those students. We're meeting their needs, and in essence, we're removing the barriers to their development, to their growth, also, and to academics. So we are really excited to be able to say that we say to our district leaders, our board of trustees, if you give us the positions, you give us the clinicians, we can truly, make a difference in our children's lives. Community organizations and relationships are important. Our goal in our district is to build those alliances with community organizations so they too can come in and connect with the students and build those relationships so that children have a trusted adult to talk to interface with, so that they can build trust and begin that healing process. Policies and laws are important. In Texas, we have a new law, House Bill 114. I don't know if you all have heard about it, but it's made a huge difference. It's now mandatory that if a child vapes, that they have to go to DAP, they have to go to alternative school. And so what does that mean? What does that mean for our students? If they are vaping, they're caught at school with a vape, that's a separation from the school environment. That's a separation from those trusted adults on the campus, which means there's some disruption in their ability to learn, receive high quality instruction. And so policies and laws and knowing what those are important. So as a district, as an organization or an agency, you want to think through, how do we avoid children being disconnected from their peers, disconnected from those trusted adults on the campus? And so knowing those laws and policies helps us with programming. So we put programming in place to address our students proactively so they don't even fall into that pipeline of alternative school and so forth. And then lastly is society, and then understanding that as a society, it's all of our responsibility to support our students, to understand what they're going through, to understand their experiences. And then as a society, meaning as a school district, as our city leaders, our government structures, all of that plays a part in how we address our students that are experiencing trauma. And it's all of our job, we believe, to build in the supports that they need to recover from the traumatic experiences that they have. All right. So I believe at this point, I think, Crystal, this is yours. You're going to invite our participants to put their answers in the chat.
Yeah, we're just going to have them put it in the chat there, Brandon. In the essence of time, we will look at it and then we move on to the next slide.
And so the question is, how is your organization addressing the youth mental health crisis? So I've seen some of the comments in the chat, but if you could just tell us, how are you addressing the youth mental health crisis? What are some ideas or some things you're doing within your organization to support our youth? And so we'll just take about a minute to let you do that. So providing support to the parents. Parents are critical, yes. Youth mental health first aid, we are implementing that in our district. Wraparound support, yes. Wraparound support is vital because we know, yes, there might be a mental health need, but there's other needs that need to be addressed to support that child's growth and development. Parental support, I'm saying that a lot. Guidance lessons, yes, that's important. All right. And so mobile crisis, I see that a lot. And we do have what we're endeavoring to do in our district is develop a crisis team that can really support students, not just in the moment of a crisis, but then the follow-up is important. So I'm glad to see that there's some other organizations addressing crises with our youth. Okay.
I think we jumped forward a little bit. Okay. So kind of leading into that, right? We talked a lot about ACEs, how it impacts people. We also have to think in a trauma-informed care lens type of way of how can we prevent some of those adverse childhood experiences? How can we mitigate some of that impact? So when we think about ACEs, typically an ACEs assessment is focused on the individual and the household. But when we are talking about the continuum of care is how are we addressing that with the community, right? So this is our school system that we're part of. How are we talking to principals, administrators, every single person on that campus that touches the life of a student, right? How are we providing some of that additional information and collaboration, right? So I heard some of those peer groups, mentorship groups, education, parenting education. I think I even expanded further. We talked to community partners. So I'm talking to local law enforcement. My particular clinic is in an area of Dallas that has a pretty high crime rate and community violence rate. And so not only am I having conversations with Dallas ISD Police Department, but I'm also talking to City of Dallas Police Department in terms of how can we support our community? How can we provide education? How can the officers view children through a different lens in terms of response, seeing the needs underneath some of these overt trauma responses or behaviors? Neighborhood associations, community partnerships, if you have nonprofit organizations or collaborators around you, because I know sometimes you're in a rural or smaller district and funding can be an issue. So it's leveraging those relationships of organizations that are currently present to see how we can collaborate effectively to bridge some of that gap. And then we're also looking at some of those environmental factors. So in terms of, are you in an area that has a lot of natural disasters, droughts, flooding? Is there some toxins in the land? And so in mental health services, we're very fortunate to also have psychiatrists that work with our department. And I'm going to give an example. Like I work in an area of Dallas that it was very industrialized and there were a lot of factories. And as a result, lead and mercury poisoning in the land and the water has impacted. And so, it's looking at the holistic person and the whole being. And so our psychiatrist, will do some blood work and recommend some testing. And we found that some of our students that were showing more overt aggressive behaviors were exhibiting higher levels of toxin exposure in their blood. And so, it started additional conversations, not only in the emotional and but as well as like the physical health aspect of it. And so building that collaboration, building that communication is a huge factor. And when we're talking about that trauma response, we're looking at it from multiple lenses and having those conversations. And so I would say if you're in a community that has some challenges with resources or funding, it's building that voice together and trying to find ways that you can work together to meet that response of the youth. And so, of course, some of those recommendations are those family-based intervention, structured parenting skill classes, establishing appropriate parent-child communication, community involvement, so mentorship, psychoeducation, collaboration with different groups, and in order to create a better understanding of trauma, of how it impacts us on multiple levels, our emotions, our cognitions, our physiological responses, our behaviors, and even our spirituality. And so how can we attune to those needs and wants that our community has? And so for trauma-informed care, one thing in terms of having a trauma-informed care lens is that we're coming in with the basic realization that trauma happens. And not only could our youth and the families that we're working with have experienced trauma and be bringing this trauma experience forward, but we also have to think about how we are attuning to the needs of our staff and our workers, right? Our internal stakeholders. Are we recognizing the sign of trauma? Are we responding with a trauma-informed care lens in terms of, are we attuning to their needs, to their emotions? Are we creating a structure for safety and collaboration where people feel like they have a voice and are empowered? Are we instilling hopefulness in every aspect of our system? And are we honoring the resiliency that exists in order to move forward that process of repair, of reconnection, and of healing as we're moving forward? So responding with a trauma-informed care lens and providing support and intervention to resist re-traumatization. And so the 6 principles of trauma-informed care is ensuring that we are opening a safe space and environment, but also experiencing a dialogue of safety in the way that we're communicating. Collaboration and mutuality, knowing that everybody has a history, knowing that everybody has a voice, communicating with transparency. That consistency is so important in terms of creating that trust. And if people feel like they're being heard, if people feel like they're being valued, right, we are empowering them to have a voice and a choice so that they can advocate for themselves. A lot of times we start as the advocate, but what we want to do is empower youth and our community to start being their own advocates as well, moving forward in that collaborative piece. Providing peer support, but also having an understanding of cultural, historical, and gender issues that could also be impacting some of our responses and the way that we are connecting and collaborating with each other. And so these are just some suggestions in terms of interventions and supports that we do in terms of it's. So we're not recommending that you all implement this. So these are just some of the things that we have invested in terms of training for our team, which is our mental health clinicians, but some of the programming that we've also worked with senior leadership within the school district to do campus-wide or district-wide. So we've brought in programming as trauma and grief component therapy, cognitive behavior therapy, some trauma-informed cognitive behavior therapy, family therapy or systems approach. We've also invested in training for our clinicians for EMDR, psychodrama, expressive art therapy, and Sandtray, and of course, play-based intervention, mindfulness intervention in groups. As well as some of our district-wide initiatives have been the implementation of youth mental health first aid training for the district, making sense of your past worth, which looks at trauma and attachment and some of those trauma responses, as well as trust-based relational intervention that Dr. Purge and Dr. Brown will go into in more depth moving forward.
Okay. So one of the things that Karen Purvis from the Purvis Institute of Child Development charges us to do is when we have behaviors that are showing up in the classroom, some of the trauma consideration that she suggests and we would like to express to you is to look at the behavior and decide, is this willful disobedient or is this survival behavior? So a lot of times we see a child show up in our alternative school in the classroom and they are struggling. And automatically we say, this is a willful disobedience. So the thought behind willful disobedience is I can or I could if I wanted to. And so because I don't want to, then this is the behavior that you get. What that does is it sets up a power struggle. So it's a cycle of I'm trying to win, you're trying to win. And when you have a power struggle, what happens is that the more frustrated the adult is, that increase the resistance you see in the youth. And as the youth's resistance increases, you have these oppositional behavior, and there's an increase in those. As the oppositional behaviors increase for the youth, then what you have is rejection and alienation by peer. I don't want to deal with this. This is the bad boy behavior. This is not inappropriate. This is inappropriate behavior. I don't want to be a part of this. And so the child feels this sense of rejection and isolation. Whereas as these behaviors increase in the youth, then what happens is you see the parent or the caregiver or the teacher enforces more rules, because I'm going to make you stop this behavior. You have control to stop this. So I'm going to set more boundaries and more rules. And then what that leads to, it reinforces a cycle of conflict and sends this into a downward spiral. But what if, just stop for a moment, what if we decide to look at this behavior as a trauma response, that this is a survival behavior, and then we implement trauma-informed practices. And what you're going to see is the idea of felt safety. So it's not you telling me that I'm safe, but I feel a sense of safeness. And so when there is felt safety for the child, then the child can be aware. So with survival behaviors, it's the thought that it's fight or flight, right? I'm fighting for my life, or I'm running for my life. But when you increase awareness for the child about the behaviors that they're engaging in, and what is the fear, identify that fear that is beneath the behaviors that are occurring, and then give them words to use to express. Because we often know that sometimes kids don't know how to tell you what's really going on, right? Or they may not have words to truly express what it is they're experiencing. And so when we give them words and expressions that is more appropriate, then there is reduction in frustration for the adult. And then we can move into a relationship that has a compassionate understanding. We have showed up with curiosity. We know that there is a need. We see the need. We meet the need. We give you a way to exhibit and to work on these trauma responses that you have that is more appropriate. So then with doing that, you see a reduction in manipulation, triangulation. I don't need to be aggressive anymore because I have a different way. So maybe it could be, when I get really upset, I teach you mindfulness. How do you breathe? How do you breathe through this anger? How do you breathe through this mood that you're in? And then there is reduction in control or violence. And so then you have a upward spiral, because now there is a decrease in the cycle of conflict. Dr. Brown?
So the next, we want to kind of segue into how does all of this occur, and how do we, in our district, we are really looking at how do we help regulate ourselves? How do we remain calm? And then, as Dr. Perch just talked about, how do we see this child's need? Look at the behavior as a need, not just the willful disobedience, but what does this child need? How do we help to meet that need? And then we don't quit. Like, we continue to work with our students to get them in a better place and better space to improve functioning. So with that, TBRI offers 3 strategies or 3 principles that we abide by. So connecting strategies and principles are, how do we connect with the child in terms of eye contact in terms of body positioning and proximity. How do we talk with our tone of voice? How do we get this child in a calmer state to work with them? And then we talk about empowering strategies. It's very difficult to work with a child when they have a need in terms of when they're hungry or when they're tired, they're sleepy, they didn't get sleep the night before. So you have kids potentially coming into school late, but it's because they stayed up all night and they're just not in the best space for learning that day. Do they need hydration? It is really important that we are meeting those biological needs, those physiological needs that kids have in order to get them into a good space. And then correcting strategies. How do we correct kind of at a scaling, just in terms of scaling? But so does our ability to connect kind of match what the behavior of that child? So if the child is speaking in a low tone, we're not coming with a loud voice. We're actually matching that child's behavior. So it helps to create a sense of, as Dr. Purge talked about, felt safety. They feel safe. They feel that we understand what is happening with them. We want to know more. And our behavior then helps to regulate their behavior, that whole co-regulation aspect of things. And again, it's building trust, building that sense of felt safety so that students feel better about taking the journey of healing and restoration. So TBRI principles are extremely important, and we do employ those in our district. And we want to always keep in mind of toxic stress and the impact of that stress on the brain. So we're going to play this very quick video that kind of outlines those connecting principles, those empowering principles, and correcting strategies that will hopefully give you some ideas on how to deal with some of the trauma experiences our students are having. So Jill, play the video.
As we develop, our brain produces 250,000 neurons every minute. By birth, we'll have 100 billion of these miraculous building blocks. But in order for our brains to fully function, we'll need synaptic connections to organize and build networks. Who we become and how we function depends entirely on how these networks develop, and our interactions with others and how we've been treated determines everything. From functions like heart rate, breathing, and basic emotions, to personality, decision-making, language, social behavior, and voluntary movement. We know that severe or prolonged abuse or neglect derails that building process, even in the womb. Distress and high anxiety in the mother allows cortisol, the stress hormone, to cross the placenta and disrupt development. When the toxic stress response is activated repeatedly, brain development and even immune systems are disrupted. Research has shown that high doses of stress hormones inhibit brain function and impulse control, overbuilding the fear center and the part of the brain that's critical to emotional regulation. TBRI uses 3 sets of principles to begin the healing caused by toxic stress. By recreating the developmental process, TBRI strives to introduce the nurturing that was absent in those toxic situations. And for the child who has endured toxic stress, healing must begin with a sense of both physical and emotional safety, something this child may have never known. Connecting principles are designed to create and nurture healthy relationships through sensitivity, consistency, and availability to disarm fear and gain trust. Giving full attention, using a gentle voice and kind facial expressions and body language are just a few of the ways to help build trust. Punitive and controlling responses only feed a child's mistrust and fear. Empowering principles are designed to meet physical needs, including sensory regulation, nutrition, and hydration, and strive to be aware of environmental issues, such as overstimulation by light, noise, or smells that can trigger behaviors that often leave caretakers baffled. The goal of the correcting principles is to help guide a child through day-to-day strategies by correcting fear-based behaviors and establishing felt safety, helping a child regulate their emotions, tell their stories, and learn through playful engagement. The Adverse Childhood Experiences Study examined the effects of multiple types of abuse in childhood, and the staggering results showed that high doses of childhood adversity affect brain development drastically, leading to addictions, attempts at self-medication, impacted immune systems, chronic inflammation, and autoimmune diseases. The greater the number of traumatic events, the greater the damage. TBRI can help stop this ugly cycle. There is hope for the damaging effects of toxic stress, but it will take dedication, education, and most of all, understanding.
Okay, so thank you all so much for engaging in that little video. We wanted to just kind of play it as a way of demonstrating what happens in the brain, this child's brain, that is caused by toxic stress. And again, we offered just some suggestions on how we can begin to think through our response to behavior in a way that helps to build those meaningful and trusting relationships. And just the thought, and I know we're running short on time, but just the thought of talking with a student, every time you're talking with that student and using a gentle voice or eye contact or attending to their physiological needs, it's helping to rebuild some of those synaptic connections in the brain that begins the healing process. So we're really excited about that. This has given us a great opportunity to create a common language in our district so that it's very simple and it's understandable even to those that are not mental health professionals. We understand that kids have needs, and then what we're doing in Dallas ISD is teaching all of our staff, here's how you look at the need, meet the need, and respond to that child's needs in a way, again, that brings them to that restoration that they need. So building that common language is vital. And Dr. Purge is going to round us out with talking about youth mental health first aid.
Okay, so a lot of people are familiar with youth mental health first aid, but one of the questions that I saw in the chat, which I think is so important, when we teach youth mental health first aid, we teach our staff. So from the parking lot to the cafeteria to all the staff that touches our campus monitors, anyone that touches a student, we teach them how to recognize a student that is experiencing mental health challenges. But another important part of youth mental health first aid is how do you as the adult take care of yourself? So you guys can see everything that youth mental health first aid talked about. But one of the important things, you cannot have a school-based mental health program without implementing trainings around self-care. So not only do we expect that from our team, we also go out into the district and teach them about the different areas of self-care and how are they showing up for themselves. Because if you can't show up for yourself, then you're not ready to show up for the student. It's really a reciprocal process. So for example, for my team, I have them write in their self-care as part of their professional development. What is it that you need to be your best version of yourself when you show up for students? And if we're not watering your tank or we're not watering your tree, then you're not the best person emotionally to show up for their students. And so youth mental health first aid, yes, we talk about students, but it is also about how do you show up? Because if you're dysregulated, you're not the best person to serve the student that is coming to you who's dysregulated, because what's going to happen, you'll have a combust. So I'm dysregulated and I'm serving a child, I'm interfacing with a child that's dysregulated, and we're going to clash. So I need to take care of ourselves. So there are different things that we put in place from our cultural care team to our grief circles, to our care circles. So this is when our staff can show up authentically themselves, and we hold space and we provide additional support for them in the areas that they are needed. The final thing that we wanted to talk with you about is some of our drug and alcohol preventing intervention things that we do. So we have campus-based initiatives. So we're bringing parents in, and we're informing them about things such as fentanyl, mental health issues that they're seeing at home, and how can they help their students. We also have community initiatives. So we are in Dallas. So what we do is we collaborate with the city of Dallas, Dallas County, and we put on parent education forum because we can reach a wider range of parents, and we're talking to them about what can you do to support your student, because we need the students supported not only on the campuses, but it starts at home. So those are different initiatives we wanted to share, but your campus could be doing something different. So you could tell us in the chat some of the things that you're doing with your campus. Dr. Brown?
Yeah. And just to wrap us up, last thing we want to just kind of spotlight are our family resource centers. Many of you talked about parents, lots of comments in the chat about parents and involvement in education. They are a vital part to working with students that have experienced trauma and grief and loss and so forth. And so our district, through our last bond, put in place and is allowing for 4 family resource centers. So families can come to those centers. They get there's a grocery store, there's education as relates to bilingualism, there's mental health there. There's nursing and physical health there. So these family resource centers are really vital. They're strategically located in our neighborhoods where families can get to them pretty quickly. Transportation is not a barrier. And this is really has been a great addition in our district. 4 will open over the course of the next 3 years. We had the first one open this last few months. And so we're really excited about that. We feel like it's a great resource for our families. So just some ideas on how to just begin to address our students' needs, our families' needs, and again, addressing the trauma experiences that they're having and really working together to fill in the gaps for our kids and our families. So with that, that concludes our presentation. And at this time, we're going to turn it over to our SAMHSA team and Mental Health of America to round us out.
Thank you so much, Dr. Brown, and your entire team for this incredible last hour and a half together. I know our time went by so quickly, and there was so much information to get across. Between this session and last session, it's just so clear how many truly wraparound services your district provides and how intentional you are about those services. I think there's so much that can be learned on different levels. And I saw so many wonderful questions, comments, resources being shared in the chat. So thank you all for joining and for sharing your own experiences of what your districts are doing, what's available out there, and maybe some questions about areas that you might be needing some extra support in. I know we're right up at our time, so we won't have time to dive into some of those questions this afternoon, but the Dallas ISD team has some of those questions and some of the questions from the first session that we'll be able to provide you with some answers written out and share those afterwards, just regarding some of those bigger questions you all had. I love that last slide, and a reminder, all these slides will be included too, because there were a lot of questions about how to get parents involved, how to get families involved in the conversation, how to support teachers. And I know we talked about burnout and things like that in our first session too. And along in that first session, I know at one point in our presentation, they asked the questions, Dr. Purge asked the question, what does your organization have right now that you're doing to prevent this youth mental health crisis? And there were so many great things that you all said that are happening. But if you're someone where you're thinking, we're not doing those things yet, and where do we start? I'd encourage you to go back and watch our first session where we really talk about how to build a framework of support so that there is that wraparound care. And we even at the end kind of talk about if you have to start small, what are some of those good first steps? So I just want to say another huge thank you to Dr. Tracy, Dr. Deborah, Crystal, your entire team for being here with us today, for presenting this information, for the work that you're doing in Dallas, in your communities, for your children and your families. And a huge thank you to everyone here joining us, and to SAMHSA for making this available to everyone today. I will hand it over to Kelly. I know we're right at our 1 o'clock mark. Kelly, just to wrap us up here.
Thank you so much, Jackie. And to piggyback on what you're saying, thank you so much to our presenters for this fantastic information. The chat pod will be shared with all participants today, along with a letter of attendance, the recording link for today's presentation, and a copy of the slides. When you exit today's presentation, please take a moment to fill out the survey that will pop up on your screen. And we would like to give SAMHSA a special shout out for allowing us to share this information with you today. Again, thank you all for joining us, and enjoying the remainder of your afternoon. Take care.